2, 1. We are live now, ma'am. Please start.
Good evening, all the doctors. My name is Khushbu, GM Marketing for Eris Cardiac team. So on behalf of entire Eris team, a warm welcome to all today's speakers, Dr. B.C. Srinivas, Dr. John Matthew, Dr. Rajneesh Kapoor, and today's moderator for the meeting, Dr. Sanjeev Shah, and all the esteemed delegates today logged in for the program Crevast Academy. So, sir, at Eris, we stand for power of empathy and truth of science. Eris has always worked to fulfill the clinical gaps, therapy gaps, and diagnostics and monitoring gaps. As most of you would be aware, and we are very proud to share all the time, that as a company, we feel very good, very proud in terms of carrying out patient care initiatives. So to name a few, we have ABPM, Holter, CGM, and many such initiatives which we are carrying out more than 7-8 years, since last 7-8 years. And with these initiatives, we have touched 2 lakhs, like in ABPM, we touched more than 1 lakh patients. In Holter CGM, more than 70-80,000 patients. Apart from this, to name a few, some landmark studies we have initiated, like India Heart Study, India ECG Study. So as a company, we always believe in patient care, and that is for what we stand for. Going ahead, in today's today's program, for what we gathered today is Crevast Academy. Just wanted to introduce to you the event, which is a round the year event. So this Crevast Academy will be the conglomeration of the content curated to disseminate and master the nuances of clinical management for improving the cardiovascular outcomes. So in short, sir, we will be discussing the topics which are quite clinically relevant and which will help all the clinicians across India in managing their patients in a better way. So there will be experts coming into the forum. They'll be guiding all of you in terms of how do we manage our patients in a better way to improve the cardiovascular outcomes, sir. So the first session of Crevast Academy is on statins essential for diabetic heart. So today we will be covering 3 major topics under this session 1. The first is statins essential in high CV risk patients. Second, on guideline recommendations of statins in diabetes. And third will be early use of statins in diabetes for ASCVD prevention. So this will be first session will be moderated by Dr. Sanjeev Shah. All of you would be knowing Dr. Sanjeev Shah, but just a short introduction. He is an endocrinologist at Nanavati Mixed Super Specialty Hospital, Mumbai. He is an academician, clinician practicing for more than 40 years, expert in clinical pharmacology, working under KEM Hospital for more than 5 years. He's a researcher in many global trials since last 20 years. He has more than 50 original research papers and 20 book chapters to his honor. So with this, I would like to invite Dr. Sanjeev Shah. Sir, take us through today's session. Over to you, sir. Thank you.
Thank you, Khushbu. It's my pleasure to be part of this meeting. I had an opportunity to listen to Dr. Goldstein Brown, who got a Nobel Prize in 1985 for the discovery of LDL receptor, which led to the discovery of statin. I happened to be in the city of Dallas at UT Southwest, and I happened to listen to his lecture. At the same time, I have a sweet memory of conducting a clinical trial on gugulipid, which was a CDRI drug for treatment of hyperlipidemia in the year 1983, when we did not have anything like a statin, and clofebrate was imported in India and some patients were receiving clofebrate. In order to proceed, this is how is the agenda. We have 4 different talks, each lasting just 6 to 7 minutes. And after each talk, we would have some discussion on the relevant topic. Now, this is not a complete subject per se, The design of the whole 1-hour program is single important paper which has been picked up. And going forward during next 1 year, every month, there would be a Crevast Academy, and then one important paper would be discussed by one expert. So in brief, we are going to cover, but this attempt is to fill up the gaps in therapy, fill up and have therapeutic and clinical excellence in management of hyperlipidemia and high-risk CV individuals. I would start with the first talk, that Nobel Prize were specifically for this 3 class of the medications, which has made difference in the life of human beings. It has saved many, many lives. Insulin way back in 1921 was discovered, penicillin in 1921, and Nobel Prize for lipid abnormality and physiology was 1985. The first statin, loastatin, was developed by Merck company and launched in 1987. And subsequently, there were series of multiple statin and a non-statin lipid lowering agent. We are all familiar with that. On the other side, if we see with in spite of all discoveries and better antihypertensive, better anti-diabetics, the burden of heart disease continues to remain high. Number of myocardial infarction has reduced. Probably CV mortality also must have been reduced comparatively with the advent of statin and a better CABG surgeries. But challenges continue to remain. At a younger age, people get overweight. 2 decades early, the blood glucose and diabetes starts. Our younger population has hypertension. 1 in 4 individual is hypertensive. 1 in 10 individual is diabetic. And we are all thin fat Indians with visceral adiposity, high insulin resistance, higher inflammatory state. On the other side, ICMR studies on dyslipidemia in diabetic population shows that high TG and low HDL, which is a marker of insulin resistance, is so common. I always wondered that what is a normal LDL? What the lab prints is 130 or 110. Is it really normal? I have an expert panel of cardiologists today, and we would have some highlight on the discussion. What is an ideal LDL level? What is an abnormal level? Though our focus is today on the high-risk individuals, high-risk diabetic population, but we would touch this high disease burden adult population in the second half of life. Diabetes, hyperlipidemia, hypertension, leading to subsequent coronary-based complications, renal complications, ultimately heart failure. Almost 10% of diabetics qualify for low ejection fraction heart failure. With preserved EF, far more number would qualify for heart failure. It is a right time to have this kind of an approach. 3 tests at the age of 30, 3 at 30 checkup protocol, which was recently launched in order to prevent future burden of cardiovascular disease, again covers A1C, blood pressure, and cholesterol. So ABC remain at the focus for early detection and prevention of cardiovascular disease. That takes me to a very simple question for every adult is, who is at high risk of developing cardiovascular disease? We have too many risk equations and various applications and various formula. Are we using them rightfully for right patient in the clinic? Do we do risk stratification in most important and most high-risk people in order to get their attention and a physician attention? If we put diabetes as one of a risk parameter, automatically patient goes into high-risk category. You add an additional risk factor, patient gets shifted into further higher risk category. So American Diabetic Association recently came out for risk stratification, 3 important variables: age of the patient, existence of a previous cardiovascular event, and presence or absence of risk factors like LDL more than 100 milligram, higher blood pressure, smoking, obesity, and family history of premature atherosclerotic cardiovascular disease. Putting some of these factors into risk equation will tell you 10-year risk of an individual. Again, sometimes a 10-year risk may appear lower, but if you calculate lifetime risk of cardiovascular disease in diabetic people, you will find it's very, very high. You know that 3/4 of diabetic people develop cardiovascular disease in their lifetime. So does risk stratification of patients with diabetes benefit? Yes, it can diagnose subclinical atherosclerosis, which is present in more than half of diabetic people. It can diagnose silent ischemia and a likelihood of future cardiovascular events. A meta-analysis evaluating prognostic value of coronary artery calcium score from various studies in asymptomatic subjects indicated a linear relationship between the score and a future coronary heart disease. This is considered as one of the very, very important tests in majority of high-risk diabetic individuals. Cholesterol is still a strong and independent risk factor for cardiovascular mortality. In diabetes, the risk increases manyfold, and the absolute risk of mortality is very high for every higher cholesterol level in diabetic individual. This was an elegant paper in 2020 by Kaushik Ray and J. Brands. They wrote about a simple 3-page paper in relation to lifetime exposure of cholesterol or LDL cholesterol. And they used the data from Mendelian randomization, 50 years exposure, epidemiological studies with 12 years exposure, and various clinical trials which are done over 5 years showed that every higher level of LDL lifetime exposure was associated with higher and higher risk. So LDL or ApoB remains as one major intervention factor. There is just no low level of LDL. Every lower level would be beneficial, and your therapy targeted to achieve low level of LDL would be extremely useful. And that's how the therapy is evolving. Newer and newer agents trying to help more people to reach an LDL target. Basically, our subject today is a statin, and there are 4 different groups who benefit with statin. I have put up secondary prevention and diabetic population as extremely high risk group, and we are going to discuss these 2 groups today. The primary prevention would be discussed in subsequent months at a later meeting. We would start with the first high risk, severe risk individuals, and this is going to be our first topic. Dr. Srinivas is going to address on this subject the most important one paper published by Scott Grundy, who is father of lipidology, again from the same UT Southwest Institute. Dr. Srinivas is a senior interventional cardiologist with more than 30 years experience and working at Jaydev Institute of Cardiology in Bangalore. He had been a clinical investigator in FEMI trial, published a chapter as well as many papers at national and international meeting. Dr. Srinivas would address on the subject of high intensity statin essential in high severe risk patients. Over to you, Dr. Srinivas. You would be sharing the slides.
Thank you, Dr. Sanjeev. Can I share my?
Yes.
Yes, sir. You can make a
Good evening,
screen
friends.
Yeah.
As Dr. Sanjeev alluded to, when we have a group of patients with atherosclerotic cardiovascular disease, we saw how to risk stratify based on the ADA recommendations and determine the management group. Once we decide that, it's important that we institute lifestyle therapy. That's also equally important, and then appropriate intensity statin. This is an overall view, and then you monitor the response, and then you add additional therapy if required, especially in high-risk groups. There are two groups which are extremely important with respect to high-intensity therapy. One is those who already have an established atherosclerotic cardiovascular disease. What do I mean by that? Any manifestation of coronary artery disease like acute myocardial infarction or an unstable angina or an unstable elevation MI will be treated for this. Are patients with stable coronary artery disease, even they form a group of ASCVD. Apart from that, those who present with stroke, those who have TIA, those who have been treated with revascularization strategy for either coronary or peripheral vascular disease or atherosclerotic aortic aneurysm. These groups constitute the patients presenting with ASCVD. And that is a high-risk group, and you have to treat them with high-intensity statin therapy. Apart from that, we have other groups where in primary prevention of ASCVD, we use high-intensity therapy. Here, there are 4 people. One is when you have the primary LDL cholesterol of more than 190 milligram per deciliter. You should watch this. There are so many secondary causes for hypercholesterolemia you have to rule out, like hypothyroidism and hyponephrotic syndrome, or someone taking ketogenic diet or high saturated fat diet. So or obstructive liver disease. These individuals, you have to treat the underlying cause and then look at the LDL and then treat it. So primary LDL more than 190 is one group which will also benefit with high intensity statins. And coming to the diabetic group, which is one of the topics of discussion today, between the atherosclerotic cardiovascular risk, if it is more than 7.5% over the next 10 years, that again, especially those with high-risk diabetes futures, I'll come to that, what means with respect to high-risk diabetic features. Then when you are having a group of individuals, when your calculated risk is more than 20% over the next 10 years, that again benefits from high-intensity statin therapy. And due to some reason, you have done a coronary artery calcium score using CT, then if there is calcium, significant calcium, then this indicates that there is an established coronary atherosclerosis. This group, irrespective of the level of cholesterol, it belongs to high-risk group. So in addition to established atherosclerotic cardiovascular disease, these 4 groups are also eligible for high-intensity statin therapy. So what do we mean by high-risk diabetes features? One who has been, long duration diabetes. Long duration is type 2 more than 10 years or type 1 more than 20 years. If there is albuminuria, and then if there is estimated GFR of less than, so indicating chronic kidney disease, or retinopathy, or neuropathy, or ankle branchial index of less than 0.9. You look at the clinical trial, why they have been included. Patients with proteinuria, if you look at the all-cause death is increased, cardiovascular death is increased, MI and stroke is more, as compared to absence of proteinuria. And are we justified? If you look at the data of therapy of high intensity, it is actually, we need only if you 10-year number needed to treat to reduce one cardiovascular event is only 9. So you treat 9 patients with established atherosclerotic cardiovascular disease for 10 years, you have 1 event reduction. That number needed to treat is so low. So this is a very important group. Similarly, if those individuals with primary LDL of more than 190, number needed to treat a prevent an event is 119. Similarly, diabetics with expected atherosclerotic event in the next 10 years, more than 7.5%, number needed to treat is 15. So that is the reason why these groups have been included for managing them with high-intensity statin therapy, because it is established fact today. When we have a diabetic who is young, when the atherosclerotic cardiovascular disease expected is less than 7.5%, you look at the number needed, so slightly high, 73. That is the reason maybe you should go for moderate intensity therapy once you establish the 10 years risk. If you compare the number needed to harm, with high intensity therapy, it is 63. So it definitely the harm is definitely less compared to the gain which you achieve in these subgroups. So what do you mean by high intensity therapy? High intensity therapy is when the baseline LDL, whatever you have, if it goes down by more than 50%, that is called high intensity therapy. When your LDL, reduces by 30 to 49%, from the baseline, that is moderate intensity therapy. So to achieve a high intensity therapy, generally atorvastatin 40 to 80 or rosuvastatin 20 to 40 will be needed. So this constitutes high intensity therapy. Whereas moderate intensity therapy, you have atorvastatin 10 to 20, rosuvastatin 5 to 10, and then you have the other statins, which we rarely use nowadays. These are the two commonly used drugs. If we look at the clinical trials, the ideal TNT and the PROVE-IT TIMI-20 to actually use very high dose statin in different subgroups, and clearly showed that the all-cause mortality was much better as compared to the moderate intensity group. So today we are very clear, high-risk patients benefit most from high-intensity statin therapy. And in fact, in those with baseline LDL levels of more than 140 milligram per deciliter, 50% reduction in LDL cholesterol by high-intensity statin is going to reduce risk by approximately 40%. And in fact, even more when the baseline LDL concentrations, cholesterol is much more than 140. So high-intensity statins reduce atherosclerotic cardiovascular disease risk, and it is third much more than moderate intensity statins. So they are favored for patients who are considered at high risk. So higher doses not only reduce the events, but also reduce the total mortality. So when we have encounter this group, it is just not cholesterol. It has to be a global cardiovascular risk reduction. You should have a global approach, that is multi-pronged approach, controlling other risk factors like smoking cessation, as Dr. Sanjeev mentioned, to have the blood pressure under control, blood glucose under control, weight, to avoid weight gain, if possible, weight reduction of the weight, especially if there is metabolic syndrome. This also will facilitate in global ASCVD risk reduction. And of course, as I mentioned earlier, before branding hypercholesterolemia as primary, you need to rule out the secondary causes, treat them appropriately, and then address the cholesterol issue. When we are addressing the cholesterol reduction, one should strive for maximum LDL cholesterol from the beginning. So it is not wise to go for a staged approach with low intensity, moderate intensity, high intensity. It is always better to start when required high intensity statin upfront, so that you achieve 50% or more LDL cholesterol reduction from the baseline, so that you achieve the ASCVD reduction from the beginning itself. And of course, there is always a lingering doubt in the mind of physicians whether they will tolerate high intensity. This lingering doubt is there in a lot of physicians, primary care physicians all over the world. It's not just India. So what we have seen after studying lakhs of patients is nearly 90% of patients tolerate high intensity statins without any substantial statin associated side effects. And then you need to also understand the high intensity options. If rosuvastatin 40 milligram is not tolerated or acceptable, downgrade it to 20 milligram to get at least closer to 50% lowering LDL concentration, because as Professor Sanjeev mentioned, lower the better. That has been the rule actually, and that is what the present findings are pointing at. I'll just show you. See, yellow trial looked at plaque modification after aggressive lipid lowering with high intensity therapy, and in fact they could demonstrate in the plaques that the lipid core index, well, the bulk of lipid core actually decreases. What it means is, if there is a thin cap fibrous atheroma is vulnerable. It can break, cause an event like a MI or a stroke. The fibrous cap thickens with high intensity statin therapy, and not only that, the core lipid burden reduces. And what they have shown is the plaque cholesterol efflux capacity improves with high intensity statin. So that leads to plaque stabilization and plaque regression, which actually translates into reduction of the cardiovascular events. Look at the asteroids. Look at these images. See, I'm sorry. Okay, look at this. This IVA study, and in fact, as early as 6 to 8 weeks following high intensity statin therapy, you can see that this is the plaque burden. And actually it reduces. Not only that, the atheroma volume reduces. You look at the internal lumen, the area through which the blood flows. That lumen actually area increases. And you look at the another interesting aspect, external elastic membrane area, which is 19.05 here, actually becomes 17.3. See, with accumulation of atherosclerotic plaque, what happens is Glagov phenomenon you might have heard. The external elastic membrane actually stretches outwards to accommodate the lipid accumulation. Actually, there is reverse remodeling here with the EEM coming down as the plaque burden goes down. This is what the asteroid clearly showed. So high intensity therapy, even in short term of 6 to 12 weeks, showed this plaque reduction. Similarly, in various subgroups, so in fact, 78% of patients in asteroid showed atheroma burden reduction. In lunar, actually, various subcategories of ACS were studied with high intensity statin, and they clearly showed again with high intensity statin therapy, there was plaque burden reduction, which translates into event reduction. Suppose you have a population of intolerant, who do not tolerate the high intensity statin therapy. What do? Try to withdraw and reintroduce moderate intensity. If it is tolerated, add ezetimibe 10 mg, which acts at the intestinal villi, so that you can achieve the LDL cholesterol lowering to 50% or more. This you can actually combine. So similarly, if the LDL is still more than 140, or if it is more than 100 milligram per deciliter with additional risk factors like familial hypercholesterolemia, diabetes, severe and extensive atherosclerotic cardiovascular disease, or rapidly progressing atherosclerotic cardiovascular disease. In such scenario, you can consider adding PCSK9 inhibitor with injectable antibodies to aid in the LDL cholesterol reduction. So when you have an established clinical atherosclerotic cardiovascular disease, if they are not at very high risk, and if they're less than 75 years, still we indicate high intensity therapy, because this itself is an indication for high intensity therapy. If the LDL concentration on maximal therapy is more than 70, then try adding ezetimibe to achieve less than 70. If more than 75 years, maybe consider moderate or high intensity if reasonable, if they tolerate it. Then if there is very high risk group in established atherosclerotic cardiovascular disease, like extensive disease, presence of diabetes and rapidly progressing events or recurrent events, then this is the group wherein you probably need to consider bringing it down to less than 55. In fact, in my clinical practice, in this group, I would not hesitate to get them into less than 55 or even closer to 40 milligram. So if this is one group, maybe you may have to add additional non-statin therapy to aid the statins to have further reduction in lipid lowering. So there is today strong evidence that most patients at high risk for ASCVD benefit from substantial LDL cholesterol lowering of 50% or more. Enhanced lowering can be achieved preferably by use of a high intensity statin, or if preferred, moderate intensity statin plus ezetimibe with or without a bile acid sequestrant. Of course, many reasons exist for under treatment, but in high risk patients, clinicians need to discuss the value of maximal LDL lowering, because the LDL cholesterol, not only you should discuss LDL cholesterol lowering, you should also discuss that it is going to reduce stroke and MI, which are, which can cause significant morbidity and mortality. So instead of using only LDL cholesterol lowering in your discussion with the patient, you should also bring in the point that it is going to reduce stroke, which is debilitating. It is going to reduce myocardial infarction, which is going to be morbid and, increase the mortality. And of course, you can monitor for efficacy and adherence in this group. I thank you for the patient hearing.
Thank you, Dr. Srinivas.
Yeah.
couple of questions emerge from your talk. You have very beautifully highlighted high intensity statin. First question for Dr. Rajneesh Kapoor. When your patients get admitted for acute coronary syndrome or myocardial infarction, they've already suffered an event, they are in hospital, and you do a lipid profile, and you look at the past therapy of a statin, what kind of a statin dose people are receiving when they get hospitalized for coronary event?
I think this is very nice, Dr. Sanjeev. So this is kind of observation you are asking from me. So in my observation, mostly people are receiving very small dosages of statins once they land up in a hospital with acute coronary syndromes. Maximum dose, the usual average dose which I have seen is rosuvastatin 20 milligram or atorvastatin 20 milligram, but hardly I have seen people putting patients on rosuva 40 milligram or even more. So rather than actually following the targeted cholesterols, they are usually underdosing the statins and patients continue to take that. That is number one. Or at times, patients, they also take it so lightly or they are not counseled well that it has been started at 40 milligram, but patients, they usually find that it's not a big deal to reduce the dosage by themselves. I have seen many patients doing that also in my practice. So 20 milligram and few percentage, 5 to 10% patients may be on 40 milligram statin. Rosuvastatin I have seen once they land up with acute coronary syndromes.
For both all three experts, how frequently we need to combine ezetimibe because patient did not tolerate kind of rosuvastatin or atorvastatin? 10% or 20%?
Sanjeev sir, the percentage is low. Actually, if we advise them properly and then take them into confidence, majority of them do tolerate, and less than I would say less than 5%, Sanjeev sir. I don't. In fact, I'm very.
So Srinivas and Dr. Rajneesh, we know that all cardiology meetings and publications have quoted 9% as muscle-related symptoms, but in real world, people tend to believe that 20% do not tolerate. So there is significant disparity between what people believe and what actually happens.
Yes. In fact, if I recall, now more than 30 years of practice, actually there were only 3 cases which needed absolutely, one came with extreme pains and he was having a cola colored urine. He was in, his creatinine shot up to 5. It was a clear cut case of, myoglobinuria with, rhabdomyolysis. That case we had to stop. Second case, again, the CPK shot up with severe pains, then withdrawal of statins resulted in, reduction of rhabdomyolysis and then stop. So there are documented 3 cases I have, but apart from that, those they have muscle aches and pains. When we give, some of them were vitamin D deficient. This is one observation I have made, and I always make it a point to supplement vitamin D in these individuals. And I have noted that the muscle aches and pains do come down with vitamin D supplementation. This is my own personal observation, and I personally feel if we sit with them, convince them, they do take it.
So do any of you feel that people reduce the dose because the cost is an issue or the risk is an issue? Matthew, what do you think? Diabetic people?
Personally, I feel they don't reduce, at least in my place where I practice in Kerala, they don't reduce it because of the cost. They reduce it sometimes, they would check between the visits total cholesterol level and find that is close to normal or it's on the lower side, and then they just stop it. Or sometimes what they do is that they go to purchase and then someone will ask them, why are you on 20 milligram of atorvastatin? All of the people take only 10 milligrams, so they reduce to 10 milligrams. So these are things which, just like Srinivas told, we need to counsel patients and make them understand why they are on 20 and not on 10. Then so they may continue the medicine.
Matthew, this lab number, which gets printed as 100 is okay, is a wrong practice. People look at less than 100 and they tend to reduce the dose, which is more harm than the benefit, correct?
That is true. Yeah.
Very true.
Dr. Rajneesh, I had one point raised from Srinivas' lecture, which said number needed to treat. In one, it was 15, in another was 73. So, Dr. Srinivas, there are people who are low benefit and low risk. So, NNT is 73. But people don't remain stable. The situation is dynamic. People today are low risk, and a couple of years later, they progress into high risk. So,
I agree with you. I agree with you. Age, actually, there is a increase in the number of risk factors. And what is at 40 and what is at 50 in the same individuals differs. I fully agree with you. And the evaluation has to be continuous, ongoing with every visit. I fully agree with you. Accruing of the additional risk factors will translate into clinical events. Yes, right.
So we would leave at that point and we would move on to the second talk. For second talk, we have Dr. John Matthew. He is a consultant endocrinologist practicing in Trivandrum and south tip of Kerala. John Matthew had been part of us in many CAD conferences, as we are two course directors for many years, and we had a close contact with cardiologist group and cardiac prevention. But today Matthew is going to talk on what guidelines tell us about the use of a statin in diabetic population. Matthew, over to you.
Yeah, thank you, sir.
Your slides.
Yeah, I'm loading it. I hope my slides are visible. I'm audible.
Yes, sir.
Yeah. So I'll be looking at the guideline recommendations for statin in people with diabetes. So this is the entire thing in one slide, or rather in two slides. I'll show the next slide. But most of this has been already been covered by Dr. Srinivas. So what I'm trying to do is I'll just try to dissect this with one case. So the most important one area where it is really a difference has been made in the new 2023 AD guidelines is in the place called the place where diabetes age 40 to 75 years at higher cardiovascular risk, including those with one or more ASCVD risk factors, should be using a high intensity statin to reduce the LDL cholesterol less than 50% of baseline and to target an LDL goal of less than 70. So this is a major change which has come from the 2022 guidelines to the 2023 guidelines. So I just focus on that particular thing. All these things have already been covered by Dr. Srinivas. So this is a 62-year-old gentleman with type 2 diabetes since 12 years and hypertension. He's an ex-smoker. He's overweight. His BMI is 28. His waist circumference is 102. Blood pressure is 142/80. He's on glucoside, metformin, telmisartan, and he's on atorvastatin 20 milligram per day. And his LDL is 88 milligram per deciliter. You can see he's got other risk factors. His glucose is reasonably controlled. He's got elevated albuminuria. EGFR is good, I should say reasonable, and electrolytes are normal. So this is what the 2023 ADA guidelines recommend for people with diabetes age 40 to 75 years at higher cardiovascular risk, including those with one or more atherosclerotic cardiovascular risk factors. It is recommended to use a high intensity statin with a reduction of LDL to less than 70. And the second guideline, which is the level of evidence, is C, that same group of people. If you are not able to reach an LDL of less than 70, it is reasonable to consider adding ezetimibe or a PCSK9 inhibitor. Now, these are certain things I underline. I'm not going to say specifically, but we'll go into some things about these underlying factors. So one is, how is it different from 2022 guidelines? So the 2022 guidelines said that in people with diabetes at higher risk, especially those with multiple atherosclerotic vascular disease, it is reasonable to use a high intensity statin. So now the 2023 guidelines, what they have done is that they have said that these people are at high risk and it is mandatory to use a high intensity statin therapy in this particular group of patients. So again, this I'm not going to discuss more in detail because Dr. Srinivas has already covered the meaning of high intensity and moderate intensity statin and the difference between those. Now, if you go back to this guideline, there's something called a higher cardiovascular risk. So it's sort of saying that 2023 guidelines says that everyone with type 2 diabetes and 40 to 75 years are at high cardiovascular risk. So what is higher cardiovascular risk? Although it's not very crystal clear defined as such, you could consider putting things together. Anyone with ongoing cigarette smoking, elevated blood pressure, obesity, atherosclerotic vascular risk calculators, which has been just shown. Most of us don't use it in clinical practice. I think the time shortage is what prevents us from using it. There are softwares which can help you with this, and family history of premature atherosclerotic vascular disease. Then the American Heart Association guidelines also define certain risk enhancers, that is long duration of diabetes, more than 10 years for type 2 and 20 years for type 1. The ESC also says the same thing. Albuminuria, EGFR less than 60, retinopathy, neuropathy, or angle brachial index less than 0.9. So these are called risk enhancers. So you consider the risk factors of the patients, the risk enhancers of the patient. These are multiple things you can consider doing, looking at the risk profile of a patient, and then decide on a high intensity statin therapy. One other thing which has made life easy for people trying to manage the statin therapy for people with diabetes is that choosing cutoffs rather than the percentage reduction. I think most of us would realize that when a patient comes to you for treatment, most of the time they're already on a statin. So we are not sure what their baseline LDL was. And we start managing from that particular point where we start seeing the patient. So here in the 2023 guidelines, they say that in clinical practice, it is frequently difficult to ascertain the baseline LDL cholesterol prior to statin therapy initiation. And the focus should be on an LDL of less than 70 rather than the percentage reduction in LDL cholesterol. So this is also a very welcome move, the 2023 guidelines. You can look at LDL targets rather than percentage reduction of LDL. Now, just to revise this, I told you what is higher cardiovascular risk. And this particular segment of patients, high intensity statin is recommended. And if the patient can tolerate, just like Dr. Srinivas told, if the patient cannot tolerate high intensity statin, then you come down to a moderate intensity statin. Thank you very much.
So thank you, Dr. John, for bringing out newer changes in guideline, which cardiologists would welcome. Now, diabetologists and consulting physicians practice 10 milligram dose as the most favorite number on one side, while cardiologists always preferred higher number. Probably the guideline is pushing diabetes practitioners into selecting the higher dose. So what do you think the mindset of people, what they believe as 30% reduction in LDL cholesterol is sufficient in diabetic people? This is what had been practiced, and that's how multiple papers have shown that this is how diabetologists practice. Diabetes clinic, which is predominantly all consulting physician and primary care people. So Matthew, what do you think were the reasons why such changes were needed?
I think it is the realization that we are dealing with a higher risk profile in most of our patients, especially if they have an added cardiovascular. That is possibly the reason why these guidelines are insisting on high intensity statin therapy. Saying this, what you told is very true, that in general, I think, but in people with higher cardiovascular risk, I think most of the time we were trying to always use a LDL targets of less than 70. I think that has been done for quite some time. And even from the cardiologist perspective, most of the times for people, what we see in our practice is that people who are having the similar risk profile are managed in a similar way. Anyone with an atherosclerotic vascular event or someone who has undergone a primary PCI or any intervention would be managed much more aggressively. All the other people are managed, I think, according to the guidelines which are already there. That's what I feel in our place. Only thing is sometimes we see people who are on 5 milligram of atorvastatin. That is something which I'm not very supportive of. And another thing is just for all the cardiologists also to just put in their word, and Dr. Shah also can contribute. Is there any place we down titrate statins or we keep them at a dose? Because I don't down titrate statins most of the time. unless there are some adverse effects. So is there any place for a down titration of statins?
So,
Matthew, yeah, sorry.
excellent
Sanjeev.
question for Srinivas and Dr. Rajneesh.
Dr. Sanjeev, first, when we diagnosed diabetes, if you look at the Mr. Fit trial, it clearly showed, a lot of them, if you look at the event rates in the curves, it was the diabetics, even without vascular disease from the beginning, and died due to MI more, than people who had a prior cardiovascular event but without diabetes. So they were equivalent to people with already having a atherosclerotic cardiovascular event, and that was the realization which put them into a higher risk group. So more cardiovascular events were occurring in diabetics even without a prior MI, and it was equivalent to those with a prior MI without diabetes. So there's one comment I wanted to make. So that, in fact, indicating that diabetics have extensive vascular disease eventually. So that actually kills them more often. In fact, 70 to 75% of them, in fact, have vascular events in the end. So that has put them into, the Eris group, and why probably the guideline committees are moving towards high intensity statin therapy in this particular high risk group to, change that, course of event reduction. That is number one. With respect to the second question of reducing the dose, I rarely reduce the dose unless the patient has, side effects. Maybe in some individuals, if the LDL is less than 50, we try to reduce the dose a bit and see if it maintains less than 70, I will maintain it. Otherwise, I would go back again to the same dose with a subsequent follow-up.
So if I put the same question into different words, 100 LDL brought down to 70 and a 70 LDL brought down to 40. In both the case, a 30 milligram reduction. The incremental benefit of 30 milligram reduction would be identical.
It will not be identical. It is much more in those who have higher levels of LDL cholesterol. It's very clear now. See, suppose we have, 140 LDL baseline and 190 LDL. The man who receives, for 190 LDL will have more incremental benefits than the person who is going to, take treatment for 140 LDL, no doubt. So 70, 100, definitely there is a difference.
So Matthew, as a diabetologist, we can take a lesson that way, that rather than an LDL number of 40, 50 or 60, Dr. Rajneesh, do you think that other factors of risk factors, intervention done, ejection fraction, and those things also equally matter in assigning a risk and a benefit with lower and lower LDL level?
I think, yes, in the present era, we are using a lot of coronary imaging. So that has actually changed our way to think about the plaques and how the plaques are actually, they can lead to lots of events, and how should we really proceed. So I think we have seen now, if we have already visualized or witnessed the coronary, having an intervention done or maybe imaging done, and we know the plaque burden is relatively significant, even though the blockages are 50%, they are not obtrusive, but still the plaque burden is there. I think those are the cases which are considered, and especially with the thin cap. So those are the cases which are more vulnerable and higher risk. So definitely in such cases, keeping the LDL down to 40 is the bigger, that should be the aim and objective, rather than accepting the LDL at 70 or 60. So I think this is another corollary which should be added, that if the patient has undergone a procedure and there is a known characteristic of a plaque which makes it more vulnerable, lower the LDL, better it is in the long term to decrease the event rate.
So Dr. Matthew, do you think all diabetics need a statin very, very early in their disease? Even type 1 is not spared. So most.
Yeah, I feel so. And looking at the rates where we add people on statins, I think very large percentage of our patients are on statin, I should say, except in anyone less than, say, type 1 less than, say, 30 years, very few of them. If they have an onset of disease more than 10 years, I will start talking to them about statin. So that makes a lot of our 20s, 30s and all on statin. Because I think one of the major things which you told in your presentation is the Kaushik Ray's article on the cumulative risk of means load of LDL, which leads on to CAD. So that is a very interesting concept and something we can talk to patients, because I talk to educated patients comparing that to cigarette pack years. So if you smoke 1 pack for 30 years and 30 pack for 1 year, so you start a higher cumulative risk. Similarly, if you keep having an LDL, which may not be reaching real treatment targets, but you accumulate that for a long period of time, you are at a higher risk of a coronary artery event. So that is something I talk to patients about.
We are not getting one more point from Kaushik Ray's paper, which is more on adherence. With the kind of non-adherence in statin therapy across multiple papers, he has shown that LDL reduction amounts to only 23 milligram or 23% based on long-term data, and that creates more issues, and that's why the other therapy has a larger role and all those. But we are today not discussing adherence part, which we have kept it for future. But we move on to the next talk by Dr. Rajneesh Kapoor, who is the Vice Chairman of Cardiology Interventional Department at Medanta, NCR, North of India. He had been awarded Excellence in Cardiology and other awards. He's a well-known senior cardiologist, but his paper today for discussion is by multiple diabetologists who are in the list of authors. This is kind of a survey carried out with Indian practitioners. So this is more going to be, rather than a design interventional study or a paper, we are moving into what doctors believe, what doctors do. And this is what is a reality after having one guideline and one expert advocacy paper. Over to you, Dr. Rajneesh.
Thank you. I would say that discussion has been really productive so far, and a lot of points have been discussed already, very valid points. The crux of the matter up till now is also the same, which I am going to actually present in this paper, or I'm going to include in my presentation based on this paper. So this is an early usage of statin in patients with diabetes for prevention of atherosclerotic cardiovascular disease. A survey done on based on talking to many practitioners and having their inputs. Okay. So the facts which we have, we actually know very well. The clinical study reported only half of the people with diabetes are prescribed statins, still underused, underprescribed. I think one fact is very clear, that wherever patients are having atherosclerotic cardiovascular disease documented with risk factors, there is definitely, many high percentage of patients receiving statins. But if we leave aside this, only diabetes without atherosclerotic cardiovascular disease, I think still it is underutilized. The use of higher dose of statin is very low among these patients. I truly believe so, that this is the situation, that still many clinicians, for that matter, use a low dose statin, or at times I also give the reason behind this based on the patient's non-compliance. May not be because of cost factor that was being discussed. At times, patients become non-compliant after 6 months or 1 year of therapy, just for the sake of it. May not be a cost issue, but they feel that because the advantages are abstract, they feel okay, they continue to take it, but they can reduce the dose. So they have all the right to reduce the dose by themselves. So that is where I feel the constant bombardment on the patient's mind and creating the awareness that this is very important. The high dose to be constantly taken. This is very important in the long run. It is required to the patients at every OPD visit. This is my strong message which I like to convey. We can't relax on this. So this survey, which I'm presenting, is a report aimed to provide opinion-based recommendations for pragmatic usage of statin in diabetic population of India. Okay, so methods in this survey, these were the HCPs which were included in this survey, mostly were diabetologists, endocrinologists, consultant physicians. Discussion, a questionnaire was given, and it was it was asked that they should fill this questionnaire, and based on that, this survey actually deduces the inferences drawn from this survey. The majority of HCPs, 56%, mentioned that they would initiate statins in patients aged 41 to 50 years, irrespective of their total cholesterol, LDL cholesterol levels. So almost 50%, almost half of HCPs, they are aggressive in starting statins in these patients, but still, so that means the cup is only half filled. Still it is vacant. So early initiation of statin in diabetes with additional atherosclerotic CVD risk factors will help to reduce cardiovascular disease in those patients. The strong evidence that there is a group, 61%, they feel that there is a strong evidence in this favor, and it will lead to this kind of outcome to reduce the cardiovascular disease in these patients. Every patient with diabetes in India, whatever the age, 40 to 75, with no atherosclerotic cardiovascular disease should be on at least moderate dose of statin for prevention of atherosclerotic CVD. This is the major issue. I don't think the talk of the symposia is the patients who already have clinical disease. The talk is, the basic issue is whether for prevention, all diabetic patients should have a moderate dose of statin. And thankfully, still many feel that yes, there is a strong evidence. If this is given, it will lead on to the primary prevention of atherosclerotic CVD disease. 41% strongly feel in this opinion, and 48% also feel that it would lead on to this. So there is a good perception, there is a good thought, there is a good conviction amongst HCPs who feel that these are the subsets. So let's see the atherosclerotic cardiovascular disease risk factors recommended to consider for early statin. Now, if we have to put under a percentage graph, that which is the risk factor whereby everybody feels that this is the risk factor where it should be very strongly recommended in patients with diabetes. The family history of atherosclerotic cardiovascular risk factor, I would go a stretch forward. If the family history is strongly positive, or the family history of strongly positive means less than 50 years of age in the family, patient had family members had a cardiac disease, CABG or angioplasty or MI, that is 77% strong recommendation for start of early statin. Hypertension, increased total cholesterol, smoking, BMI, they come after that. So based on this, this comes out, and I think this is quite good. And I also believe that a strong family history makes the person very highly vulnerable for events in their lifetime. So they are very highly vulnerable. Early statin makes very good sense in those patients. A total of 98.9% of HCPs agreed or strongly agreed that early initiation of statin in patients with diabetes and atherosclerotic cardiovascular disease risk factors will help reduce the CVD risk. Again, around about 90% of HCPs agreed that every patient with diabetes in India with no atherosclerotic CVD should be on at least moderate intensity of statin therapy for atherosclerotic CVD. So if we can reinforce this message, I think our objective is met. Opinion on the treatment and outcomes, a total of 78% of HCPs recommended the use of rosuvastatin. Now, if we have to pick and choose the agent from the statin family. So again, I also totally concur with this. The use of rosuvastatin for early initiation in patients with diabetes aged 20 to 40 years, over and above atorvastatin. Majority also felt that rosuvastatin has more clinical utility compared to other statins due to better LDL cholesterol lowering effects and other pleiotropic effects. So this is the opinion on rosuvastatin. For early usage in patients with diabetes, see, this is how they feel. 36.2% strongly agree and 57% agree based on the survey. And there is a need to increase the awareness of early use of statin for primary prevention of CVD among Indian healthcare professions. I think, see, I also believe in the similar manner as given by this survey, that this is where probably the lag is happening and we should really try to push the boundaries here. So concluding, among the people with diabetes aged 20 to 40 years, having an additional atherosclerotic cardiovascular disease risk factor, early initiation of statin therapy will help reduce the cardiovascular disease risk. There is no doubt about it. This is a golden line. Initiate moderate intensity or low intensity at least, statins at least, and assess every 3 months for tolerance and compliance to the therapy. So this I would apply to all patients who are taking statins. I think there should be more stringent guidelines to keep assessing these patients every 3 to 6 months. For an early initiation approach, rosuvastatin should be preferred over other statins. So underuse of statins, this is last slide.
Yeah, so this is, Dr. Radnis, you have highlighted the paper well. I have only a point that similar to CAP survey which are done, knowledge and attitude and a belief system says that it should be used. If the effect is well highlighted in multiple CME conferences across, but if you see the top panel, SURF study in 11 countries, higher usage of statin in Europe, 87%, Asia, 51%. Asian patients less likely to attain stringent LDL, 14% versus 33%. The bottom line is again another paper which looked at 18% achieved less than 100 up to 70 and only 7% less than 70. So doctors believe, but they still don't practice what is necessary. So any light from all three, one after another, why doctors do what they are not supposed to do?
Mental inertia, this lag should be, taken off. I think we should just highlight them that it is going to reduce stroke and MI. It is not just cholesterol. I think point is, morbidity, mortality comes down. That has to be highlighted to them. And that if that is the point of discussion amongst patients, patients will agree and take it.
I will also add on to this, further what is being said now by Dr. Srinivas. So I think there is a requirement of disseminating the message and showing them the visuals. See, unless we were doing abundant coronary imaging, I think how the plaque exists in the coronaries, how it can lead to catastrophes, and how a small regression of plaques can lead to better outcomes. So if those visuals can be shown on various meetings involving all the stakeholders who actually are prescribing statins, that would go a long way in really giving them a concrete message rather than just giving data. So probably, with data, they are still not they may get impacted for a day or two, but again, their practices may not follow. So, seeing it right at the point, I think will probably make a difference. That is my suggestion and opinion.
So Dr. Rajneesh says that bar diagram, Kaplan-Meier's curves, and all those percentage risk reduction. So Matthew, how do doctors understand statistics, medical statistics, clinical research paper? His suggestion of a real live plaque and a change is also equally important. What
No, I'm not saying that is not important. That is very
No, it's important. It may be having more visual impact rather than a mathematical impact.
Yes.
Yeah, I think what Dr. Kapoor told is very true. I think just taking corollary, when you looked at that, I think if you remember, for people who treat osteoporosis, there was one picture which recombinant PTH company put out in the beginning, which is still not disappeared from my mind, because it shows very clearly bone is being formed. That's an electron microscopic view of the bone getting formed. So you know that this therapy is increasing the bone. Till then, we were all talking theory, the resorption is reduced, that, this and all. Here you see the bone building up. So just like Dr. Kapoor told, if there is a visual impact of this, that will definitely make a big difference. Second, another major setback that we are all facing is an alternate communication method like WhatsApp or websites and all, talking against statin associated issues. Means all those things being highlighted and blown out of proportion in comparison to the benefits it can provide. So this is actually impairing, it's giving a sort of different message to the patients. And those influencers are better than all of us put together in terms of influencing the use of this medicine. So that is again major limitation that we are facing. So they take that for granted rather than our message. And I think still, I feel that doctors are very worried about, practicing physicians are very worried about low cholesterol levels. They still continue to link old data like cognitive decline, suicidal tendencies and all, increased risk of hemorrhagic stroke. These were all data which had come initially during the simvastatin era. And people still sort of equate, even very educated doctors who are patients will ask, sir, is it okay that my LDL is 50 or 45? I told it is okay. What is wrong with that? It's not something it is very good to have more in quantity. It is something bad you have less in quantity. So things like that, I think, are impairing our general practice, I should say.
Yeah, well said. So probably we also need to educate people in social media. Negative messages circulate far more than positive messages. We good doctors remain very busy in working and practicing rather than sending WhatsApp messages.
That is true.
So some of the industry can take up a social issue or a corporate social responsibility indirectly influencing the people. With those words, I think I don't need to conclude. We conclude here. If anyone has final comments, all experts, anybody, if you want to, otherwise over to you, Khushbu. We are beyond time for closing so that people can have timely dinner.
So thank you very much, all the speakers, for the prolific talk, sharing your clinical experience, sir. So with this, I'm sure that more and more optimal use of statin will be practiced in India, and we will stress upon better awareness among patients. And this will in turn impact a lot of patients in India and save a lot of lives in India. Let's hope for that. And with this, we come to the end of the session 1, but we would definitely request all of you to join again on 13th May, which is the second session of the same Crevast Academy. So with this, thank you very much. See you soon. Thanks again. And Dr. Sanjeev Shah, thank you very much for helping throughout the program, right from the crafting to the moderation. Thank you. Thank you, sir.
Thank you, all experts.
Thank you, Dr.
Thank you.
Matthew John.
Happy Easter to everyone.
Thank you.
Thank you, Dr. Srinivas. Thank you.
Good night.